So we want to talk about a class of shocks called distributive shock. There are different causes, but ultimately the effect in the body is the same. So the initial insult in distributive shocks is either an immune response or an autonomic response, depending on the situation. Now, one of the types is called anaphylactic. So anaphylactic is an immune response because of an allergic reaction. And then septic shock is an immune response because of some sort of infection. Now, both of these are going to cause an immune response that releases a chemical called cytokines. Okay. Now, neurogenic shock is caused by an autonomic response after a spinal cord injury. This causes decreased sympathetic nervous system activity. Now, both of these things, the cytokines and decreased sympathetic nervous system activity, are going to interfere with vascular tone. So if I can't get vascular tone, I'm going to get massive, and these are the key words here, guys, to remember distributive shock, massive peripheral vasodilation. Okay. So if vascular tone is interfered with, then I can't constrict and I'm going to get all of this dilation out in the periphery. Now, for this lesson specifically, we're going to focus on septic shock because it's the most important one. It's the one you're going to see the most often. So let's see what happens in the body. You get this infection and it causes this immune response and it releases these cytokines. Okay, those cytokines are going to go into the system and cause that massive peripheral vasodilation. So if all the blood vessels out here in the periphery are vasodilated, then all that blood is going to pool out here and it can't be redistributed back to the heart or back to the organs. It just sits in the periphery, okay? So what we're going to see is that our preload, in other words, the blood that is able to return to our heart, is significantly decreased because it's all stuck out here. Remember, it can't be distributed. That's why they call it distributive shock. So we decrease our preload, which means we decrease our cardiac output. If there's nothing coming in, what can go out, right? So our blood pressure also decreases. We'll start to see that compensatory increase in our heart rate, right? But here's where we see a big difference from the other two shocks. Because all this blood is pooling out in the periphery and in the non-vital organs like the skin, we're actually going to see increased temperature in the skin, okay? So they're going to be warm, they might be flushed, and you might even have bounding pulses in the early stages. The other thing that we'll see is because of this reaction that's causing vasodilation, we can't get the compensatory vasoconstriction like we normally see. So instead of an increased SVR or an increased afterload, we're actually seeing a decreased SVR or a decreased afterload, okay? So it's a little different than the other shocks. Don't be fooled by the fact that they've got warm, flush skin and great pulses. They're still in big trouble. So what are we actually going to see in our patients? Well, first things first is we're going to have some sort of suspicion of infection. Maybe a UTI or pneumonia. So you'll see signs of that infection in addition to the signs of shock. So the biggest thing, like I said, that differentiates septic shock from something like cardiogenic or hypovolemic shock is that they'll actually have a high temperature. Now, a fever by itself doesn't mean septic shock. We'll also see evidence of poor perfusion. Remember, all the blood is pooling out here in the periphery. And so it's not getting to these vital organs, specifically the heart, the lungs, the kidneys, and the brain. Okay. So it's like taking a 5-lane highway down to 1 lane and trying to get all the cars through there. Here's your 5-lane highways down here, and your vital organs are your 1 lane. It's almost impossible to get them out of here and into the vital organs. So if this person's not perfusing their vital organs, what do we see? Well, the brain, decreased level of consciousness, kidneys, decreased urine output, right? So the one thing again that's different is because of the pooling, they're actually going to have warm, flushed skin. Blood not getting to the heart means that low blood pressure, high heart rate to compensate, decreased LOC. You're not perfusing the lungs even, so you'll see decreased SpO2. So you're still seeing the poor perfusion, but because of the vasodilation and the blood pooling, you are going to see that increased temperature and the warm flushed skin to start with, okay? So therapeutic management of septic shock is actually guided by something called the Surviving Sepsis campaign. Surviving Sepsis. We've put a link to the most recent guidelines in the outline for you, so you can see the details if you want, but we're going to highlight the most important points you need to know. As always, we want to treat the cause. So the big thing is that we want to start broad spectrum antibiotics within 1 hour of recognition of sepsis. Now, remember, before we start antibiotics, we have to draw blood cultures first. If we give antibiotics before we draw blood cultures, we may not be able to know what the actual organism is. Now, with septic shock, what we've also found is that they benefit from aggressive fluid resuscitation. This helps to increase their preload. And therefore increase their cardiac output. So we usually give about 30 mils per kilo of body weight. So a 100-kilo man would get about 3 liters of fluid in this resuscitation. To maintain their blood pressure, we're also going to give vasopressors. But again, if you remember from hypovolemic shock, we always want to start with filling the tank first. So we give them that fluid resuscitation, and then we start to squeeze the vessels to increase their blood pressure. Usually the goal is to keep the MAP greater than 65. So we may need an arterial line so that we can monitor their blood pressure closer. Just depends on what's going on. And then finally, one thing that we're going to do in septic shock is we're going to monitor their lactate levels. Lactate is actually released from the tissues when they are lacking oxygen. So lactate, lack of oxygen. So as we work to improve the cardiac output in a septic shock patient, we should see those lactate levels that were high start to come back down again. So make sure you check out the lactic acid lesson in the labs course to learn more. There's lots of nursing priorities for this patient as well, one of which, again, being that they need to be in an ICU because this is shock. But here's the top 3 concepts. Perfusion is your first concept because this is a perfusion issue, so we want to keep their MAP greater than 65. We can also give fluids to help improve their preload. Then infection control. Obviously, septic shock is caused by an infection, so we've got to get that under control. We're going to draw blood cultures and give antibiotics. And then oxygenation. Not only are they going to have decreased oxygenation to their tissues, but they may actually struggle to protect their own airway, especially if they're having decreased level of consciousness and they're just exhausted. So we always monitor that and intervene as necessary. Now make sure you check out the outline, care plan, and case study attached to this lesson to see a ton of details about specific nursing interventions and get a really good picture of what this looks like. So let's review. Distributive shocks like septic shock are caused by some sort of immune or autonomic response that interferes with vascular tone and triggers massive peripheral vasodilation. So that blood is going to end up pooling in the periphery and it just can't get back to those vital organs where we want it. So we use the Surviving Sepsis campaign guidelines. So we want to give antibiotics as soon as possible. We're going to fluid resuscitate, again, about 30 mils per kilo. We're going to give vasopressors to improve their blood pressure, and we're going to monitor their lactate levels. We expect to see it decreased as they get better. Now, nursing priorities, again, perfusion, infection control, and oxygenation. Remember that this is an emergency, just like any other shock. We need to advance their level of care to an ICU. They might need to be on life support. So make sure that you call a rapid response or call for help, whatever you need to get this patient where they need to be to get help. So again, make sure you check out the care plan and case study attached to this lesson to get lots of details and rationales for interventions. We love you guys. Now go out and be your best selves today. And as always, happy nursing.